I hope with this light you woke up. Woke up.
Yeah, that's true.
Adrenaline, a little bit of adrenaline.
Are they going to tell us to go? Or?
Okay, that is bright.
It is actually bright now, yes. And my glasses are a bit smeary, so I've got...
So I speak very slowly, so please give me time. I'm very slow when I speak.
I will give you time.
I'm not so fast like John. you speak very fast. I mean,
Yes.
very, very slow. So,
Yeah, I promise.
so to express a concept, I have to take some time. I do a lot of interview at the radio. I'm always embarrassed because journalists, they speak very, very, very fast. When I ask a question to me, I start to be so slow.
I always find the worst thing the journalists do is that there's a researcher that meets you,
Yeah,
and they say, "Oh, thank you for coming in," and they ask you a few things, and you give a few answers.
yeah,
And then when you go live,
yeah,
the journalist
yeah.
says, "So
Wow.
we heard A, B, C."
Yeah.
And you go,
Do with some sunglasses, to
say.
be honest.
Yeah, really.
That's happened all the time.
Yeah. Exactly. Yeah.
Really good. Double thumbs up.
Let's have some water as well.
Are we good to go? Good afternoon, everyone, and welcome to our great debate. I hope you're enjoying the conference. I've had a fabulous day, and it's great to see so many people still here, although I can't see you at all. So, after a 40-year silence, we are witnessing an explosion of interest in the therapeutic potential of psychedelic agents such as psilocybin, which is the active compound in magic mushrooms, dimethyltryptamine or DMT, which is similar to the active ingredient in the plant ayahuasca, and other substances like MDMA. These agents are being promoted as a new era in psychiatric treatment, and commercial investment is thought to be in the order of $2 billion. Yet the evidence base, particularly in the addictions, lags behind the growing public interest. So today I'm going to be moderating a great debate on the psychedelic-assisted treatment for substance use disorders, long overlooked or now overhyped. We're going to hear from three clinician researchers involved in studying the therapeutic effects of psychedelic-assisted treatments. On your right, from Berlin, Dr. Andrea Jungaberle, who's a clinical specialist in anaesthesia and emergency medicine, a psychedelic therapist and the chief medical officer of the OVID clinics in Berlin. In the middle here, we have Professor Gabriella Gobbi from Canada, and she leads a basic science research laboratory, holds the Canadian Research Chair in Therapeutics for Mental Health, and works as a staff psychiatrist at the Mood Disorders Clinic of the McGill University Health Centre. And to your left, Professor John Marsden, Professor of Addiction Psychology and Deputy Head of the Department for Addictions at the School of Academic Psychiatry, King's College London, and a practicing psychologist. Unfortunately, our fourth panellist, Dr. Tomáš Páleníček, was unable to join us, and so we will just be the four of us today. Before we get going, I'm going to ask each of our panellists to actually provide their disclosures that are of relevance to the debate today. So starting with Andrea.
Okay, next to my clinical work, I'm also a shareholder in OVID Health Systems, which is a small for-profit exploring the options for legal psychedelics in the future. I'm a study therapist at Charité Health Center on the episode trial looking into psilocybin for TRD, and I'm also one of the owners of OVID clinics.
Thank you. And Gabriella?
Okay, my research on LSD is sponsored by the government of Canada, CHR, and by a foundation, Alan Edwards for Pain, as well by a company. It's called Diamond Therapeutics. It's a company in the area of psychedelics.
And John?
So I have no commercial disclosures that are relevant to this talk. I have a university appointment, an honorary NHS appointment, but I do want to disclose that as a newbie, I'm going to cut my teeth in this area with my colleagues in London, where we're going to be running a phase 2A/B small-scale study of patients with alcohol use disorder who will be experiencing 5-MeO-DMT.
Thank you. And I'll just introduce myself. I'm Nadine Ezard. I'm an addiction medicine physician from Australia. I'm the clinical director of an alcohol and drug service in Sydney, the director of the National Centre for Clinical Research in Emerging Drugs, and conjoint professor with the National Alcohol and Drug Research Centre in Australia. And my disclosures, I'm also publicly funded, but I am an investigator on a small pilot study of psilocybin for methamphetamine use disorder that's recruiting. So the contemporary evidence base in the substance use disorder space for psychedelics is arguably slim. There's only one recent published double-blind randomised control study by Bergenschutz and colleagues showing significant but moderate reductions in alcohol consumptions over 32 weeks. And this was in a group of people that were drinking only on 50% of the days and had at least 4 out of the past 30 days where they were drinking around 60 or 70 grams of alcohol a day. So arguably not the kind of clients that will come to my practice, so more on the lower end of the alcohol use disorder spectrum. So, Gabriella, I'll start with you. What is the promise of psychedelic treatment? Is it for treatment of mild substance use disorder, severe disorder, relapse prevention, or treating comorbid mental health conditions, or is it a trans-diagnostic treatment?
This is a big question. Okay, I respond this question with the studies that have been published. As you say, very recently a study on LSD and alcoholism has been published, where they see a reduction in the psilocybin group, a reduction of heavy alcoholism. In particular, in placebo, they see 9% of reduction, while in psilocybin group, 30%. And then we have also a lot of study from the 60s, before the prohibition of LSD, from between 1966 and 1969, where we see that LSD and also psilocybin can be good to treat alcoholism. In this study, what we see is mostly alcohol reduction, substance reduction, but also withdrawal symptoms can be reduced by LSD. And also there are a significant group of people that stay abstinent after several months of treatment with LSD. I spoke mostly by talking about LSD because most part of the study in the past have been done on LSD. But we have study also on psilocybin, a lot of study ayahuasca and ibogaine. So I can say yes, is promising psychedelics, but we have to know more. Another thing about comorbidity, it's true also psychedelics can treat the comorbidity associated to addiction, in particular LSD. We saw in my laboratory that a small dose of LSD are very effective for anxiety. So this is maybe also why LSD is very effective in alcohol use disorder, because there is a big effect on anxiety component. And we know that psilocybin also can treat depression. So psilocybin can be also used to treat depression associated to substance use disorder.
So you think it's just for the comorbid mental health conditions rather than the substance use disorder?
No, I think it's both. Both.
Okay.
I think it's both. There are two components in psychedelics. One in my opinion, directly on addiction, because we study also the circuit of dopamine, they're very effective, but one component, especially low doses, microdoses, also on anxiety and depression.
Okay. But we're talking about the psychedelics along with talking therapy. So isn't psychedelic-assisted therapy just talking therapy with a novel hook to get people into talking therapy, Andrea?
Well, I would say no. In my opinion, we have a combination treatment here, a real combination treatment, because there is the neuropharmacological level, there is the neuroplasticity being increased, for example, in psilocybin. It's been shown very nice that this is actually happening. And there's also this afterglow situation where people are emotionally much more open to therapy. And interestingly enough, what we see working at the moment, for example, both with ketamine and psilocybin, is that therapy goes deep far quicker. People go into places that they might not have gone with a therapist in building relationship, looking at difficult emotions. And it is, what I would say, the important question is not, is it psychotherapy with a novel hook, but is it psychotherapy? Because this is something that is being debated as well in the field. If it's just the substance, just make it safe and off you go, or if it really is psychotherapy in a combination treatment with a substance that is used as a catalyst for psychotherapy.
People talk of the importance of the mystical experience and go to some efforts to actually study the degree of mystical experience when people are having psychedelic therapy. John, how important is the mystical experience, do you think?
Well, I think if it's important to the individual, once they emerge from being exposed, and this, we have to understand this is a profound experience. This is not a trivial exposure. The compounds we're talking about are powerful, sometimes intensely so. The one that we're going to study, our group has been involved in a study to get the right dose using healthy subjects. And sitting with people who have been dosed. It's a profound experience. So what's fantastic, I think, is that I don't know. And that doesn't matter, because what I'm hungry about is to find out from the individual afterwards, what did you make of that? Do you attribute the experience spiritually in terms of mystical precepts, etc., or is it much more pious? I don't think it matters as long as it gives us the hooks that you speak about, Nadine, that we can use psychotherapeutically. That's the current change mechanism that's on the table. And as a newbie, I wouldn't go against that, but I suspect that there will be a variety of attributional experiences, and that we've backed a horse at the moment. There'll be others, and that's okay. We'll find out.
I'm against this idea. I think it's a very important component of psychedelics. First of all, I think the psychedelics work at two different levels. Microdoses that are kind of Prozac because they act on serotonin system, so we have the anti-anxiety, antidepressant level. And when we go at highest dose, we have the hallucinogenic effect. We see this also in mice and rats. In this state of hallucinogenic effect, there is the mystical experience. And we saw also in the study on psilocybin depression that the responders were people that had the mystical experience. This is very important. Also, when you talk with people that responded very well to psilocybin studies in depression and as well in alcohol, you have this subgroup of people that really report this mystical experience as a factor to recover from depression and alcoholism. Wait. The mystical experience is not a religious experience. It's a cognitive and experience, higher experience, where people that suffer can have a meaning of their suffering, of the trauma, can have a awareness that before they cannot have. So this is not trivial. It's something from a cortex point of view very important.
What you overlook is the fact that when you survey people's experiences, you also get commonly people saying this was ineffable. I couldn't make any sense of it. And again, that's fine. If it translates, I mean, if we stick with depression for a minute, and let's inhabit addiction with permission, Nadine, as we go forward. But it seems to me there's a very simple kind of mediating process with depression. Depression is loss, isn't it? That's the fundamental Beckian theme. But usually it's maintained by two things: self-attacking thoughts, inactivity. So you don't do things that might otherwise change your mood. You're stuck. So if this means that someone they interpret it spiritually, that's fine. I'm happy with that. Why wouldn't I be? But it's got to reduce self-attacking thoughts, because that's the symptom of depression.
Yeah.
And with addiction,
Exactly.
it's got to make a difference when the person is exposed to risky condition triggers, such as, and they're endless with alcohol, for example, people, places, objects, smells, times of day, images. That's the process that this has got to work in. Well, or if it doesn't, then we really are in the black box, seems to me.
So how can we study these psychedelic-assisted therapies when the psychotherapy isn't standardised and we don't know the effect of the drug either? So when we study them, we're basically studying two unknowns simultaneously, the drug and the psychotherapy.
Well, that's exactly the situation. And this is also a novel situation, because all the trials that are happening now are basically tests that are designed to check for drug effects. So what we're trying to do at the moment is get to the point where actually these substances can be made prescription medications, and then the real work is starting, because then we have to work out, okay, we know it somehow works, but we then have to see what works best, what paradigm, what psychotherapeutic background thinking, which interventions will work. And there's like the same war of schools of thought happening already in the field that we see somewhere else. We've got people with a psychoanalytic background to say, okay, this has to come from depth psychology. Others say, okay, we can do a lot using CBT, especially third wave, like ACT models to work with this. And one thing I would just like to point out, this whole discussion about mystic experiences, I don't think it makes that much sense, because let's boil it down a bit. Let's talk about mystical type experiences, because we don't have to come into purity wars there if this is mystic or not. It is strong, it is very, very demanding of people, and it's of importance. So, and the next thing is the questionnaire that is mostly being used to see if it's a mystical type experience, the MAQ, is something that in most of the items also goes for very immersive experiences. And even if you haven't met God, if you have had a very immersive experience, you're going to score to a point where it's going to be noted down as a mystical type experience. So to me, I think that point isn't actually that important. And to a man with a hammer, everything looks like a nail. So, and what is important is really what you've been saying, what people make out of it. The experience, to me, is just 10 to 20% of the whole thing, but working with it, taking something out of it, and then living your life in a healthier way is the most important thing.
Yeah. So, sorry, Andrea, you said we need to get these drugs available on prescription and then we can study the psychotherapy. But how do we get them on prescription when we don't know what they do? And we can't blind people to the effects. So the Bergenschutz study that I mentioned before, 90% of participants and researchers guessed whether they're on the active or the placebo. So how can we actually study these drugs if we can't even blind people to it in a classic gold standard double-blind randomized control trial? John?
The hospital pass. Yeah, it's really challenging, and therefore we've got to have a very careful stage-based approach, which I think is in evidence, which is really, really good in terms of the sort of hype part of this evening's debate. I think there's plenty of evidence of a very measured, stepped approach to what questions can be answered. Safety first, feasibility for recruitment. As we were discussing, some of the recruitment timelines are worryingly long. If I said to you, oh, Nadine, we should do a 2x2 factorial, it starts to fall apart in terms of having the purity of being able to do that. So I don't think we're going to have that level of design stricture, but I think the way we would think of it in our group is that we really bring a standard CBT, which is already personalized, and we see what happens. You know, counterfactually, patients in London, in South London, in our clinics are receiving a standard CBT offer right at the moment. So what we're going to do is parachute in a single 5-MeO-DMT experience. And I guess the thing I wanted to point out, or make reference to, which we haven't yet, is if we get to find that the patient changes the way they think about themselves, we don't mind how, do we? I think we've agreed, it doesn't matter. But what we've then got, we're then asking amazing questions about the nature of change and nature of how addiction can be quite malleable. And maybe that means that we need more simple designs that would enable these exposures to be carried forward to formal license. That, I think, is where we want to go. Already we can see that it works for some people. Whether it continues to move from efficacy to effectiveness is that million-dollar question we suffer all the time. But I think it's game on.
But other ideas, if you see the study of the 60s, they were very creative. They study psilocybin versus ephedrine versus amphetamine versus drugs that anyway change your state of mind. This could be a very interesting control for these kind of studies.
Because I think, I mean, the expectancy effects are going to be considerable in this, so finding another active medication might be active comparator at least. John, you mentioned safety as one of the initial kind of steps in the evidence building, but we know that psychedelics like LSD can be associated with harms such as psychosis, anxiety, or even perhaps substance use disorder itself. Won't that limit the potential therapeutic application of these treatments? Gabriella? You mentioned
there is some evidence that psychedelics can be a little bit like cannabis in a vulnerable population, in people with a predisposition to schizophrenia, bipolar disorder, can trigger and psychosis, can trigger mania. And we already see this happening at the emergency room. So we should be very, very careful to use this substance in this population. Also, in terms, today people talk about legalization of psychedelics. We should be very, very worried also about the mental health of the general population.
John, did you want to add something to the safety question?
No, I think so far what we feel is the state of knowledge is that they've got a pretty benign safety profile. You know, they look safe. And the context in which participants, patients will be exposed to them are very, very safety-forward, controlled, but not classic hospital. You know, they are therapeutic settings. So we will find out. I mean, I think there are questions, as you rightly say, about making sure. This is the devil of trials, isn't it? Is making sure we want to open, to your point about severity, Nadine, we want to open these studies in the future to as many people as possible so that we don't have a very narrow capture. But at the same time, there are indications that would make someone vulnerable potentially. And I think that again feels that's being done thoughtfully and appropriately at the moment. I think there are other things in the debate about hype that are more concerning, but I think this is a very safety-attuned field at the moment, and rightly so.
So perhaps a bigger threat at the moment is the drive, I mean, you pointed out before, the drive to monetize psychedelic psychotherapy. Is that a concern that you have, Andrea?
Definitely. I've been in this field now for about 15 years, and back then, the conferences, the meetings was cozy meetings of enthusiasts getting together and hoping for, a brighter future for a method they believed in and worked for. And now we've got billion-dollar stock market firms that are liable to their investors. And suddenly there's a pressure of bringing this into the market that also will make it difficult to do it diligently. And I think what we should not underestimate is these substances can do as much harm as they can do good. So you need people who are well aware of what's happening inside people when they are being in those psychedelic spaces. You have to have therapists who have the ability to hold this space and their own stuff with themselves. And this takes training, this takes years of learning to think in and around these issues. And if suddenly we have a drive to have people go to 2 weekend trainings and here you go, this is not going to work. And also, I think we've done something very typical in our society. We've gone from totally demonizing these substances to glorifying them. And like always, the same with cannabis, the truth lies in the middle. And I think the pendulum has to swing a few times, but what we don't want to see is lots of people being harmed in the process. And this is where we are all in this field in charge of making sure this can really happen safely.
I think you're absolutely right. I also think that we've heard. I mean, we've had such a superb program today. But I mean, we heard about how the war on drugs would never have countenanced the reality of cannabis policy at the moment, for example. And so this long-rooted but obscured history we're talking about has been blocked by war on drugs, and perhaps blocked by recreational use as well. But the point I'm getting to is that some of the small pharma companies that have been involved in bringing trials to fruition have taken a good leadership role, I think. The state wouldn't do it. The VCAP element on top, as you mentioned, I think that looks, anyone on the bus looking at that would think, they'd look at that askance. They'd say, you're monetizing that early. And the idea that you're going to make millions of dollars out of this is a real worry. And it obscures the measured stage-based approach to science, I think, and in a way that is unfortunate. Because there could potentially be something amazing here if we get it right. And you've had an amazing career so far, and you've got to continue for another 2 decades being a trailblazer. And we don't want the media being told that this is a panacea, that everyone is going to be cured. We don't want to give people false hope, and we don't want to go down false paths scientifically. So we're right on that precipice, I think. It's a very charged moment.
I would like to point out one more thing. What happens to the people who cannot be helped by those therapies? Because what we're creating at the moment is a vortex of expectation, of hope. And as always, not everybody is going to be suitable for this kind of treatment, even if they are being admitted to trials or to treatment, they might not benefit. And then you've got people who were given a huge amount of hope and were again disappointed. And this is dangerous, both for addictive patients and for people in depression and so on. This is something that worries me most, to be honest.
But how can we avoid this? I mean, Wayne Hall and Michael Farrell have recently written on the mistakes of the past associated with over-enthusiasm for psychedelic therapies. How can we avoid these pitfalls? I mean, you're saying we shouldn't over-egg the kind of promise of the psychotherapies, but how can we avoid that when there are already commercial interests and you can go online now and go away to a camp for the weekend if you want to pay you $3,000. So how can we actually, you pointed out before, Gabriella, that if the psychedelics are too available, we might miss the opportunity actually to study the therapeutic potential, as I think you believe for
I live in Canada, so in Canada we have legalized cannabis in 2018 with the promise to do more clinical study, to have more accessibility to medical cannabis. But at the end of the day, we have a lot of recreational cannabis. We can buy THC up to 35%, up to 80% of vaping. So we just increase mental health issues in the population. And on the other hand, as a doctor, I can't prescribe THC or CBD because it's not paid by the government. people have very low accessibility to CBD, medical CBD or medical THC for pain. So this is the situation. I'm running a clinical trial on CBD. I cannot find pure CBD for my research. So this is the situation where the company take the control, the power for recreational cannabis by creating more addiction than medical help. I'm afraid that with psychedelics something can happen if the business goes faster than medical community.
Yeah. It's funny the things you remember or the things you don't forget. When I was traveling here, I suddenly was reminded of, I'll get some of the details wrong, but I think it was December 2003, and there was a brilliant scientist, worked for a very large British pharmaceutical company, and he was interviewed for a mainstream newspaper. And it wasn't an unguarded moment. He believed it. He said, the thing is, for all medications, for all indications, 90% of medications work for only between 30 and 50% of patients, right? Now, that may have changed in the intervening years, and I can think of some medicines that are in the margins that are amazing, but we already hype. You know, when you read the label, it says this will work. Take as directed, and it may have some sides, but this is what's going to happen. We know, look at antidepressants. So the answer to the question is we have to have appropriate expectations. So ideally, it means that these aren't sort of third-line treatments, that, you know, it's almost as if you could say to someone, would you like to try this? You know, think carefully about it. This is not meditation. This is going to be quite profound. But if we tee it up as a behavioral experiment so that it doesn't matter so much if it doesn't work, then we're doing good work. If we reserve it for people who have suffered greatly and have not responded and have got to a point of desperation. I was listening acutely when you were talking, Nadine, about this, because what we don't want is for patients to say, I couldn't even succeed at that. You know, I couldn't even get that right. Then we've mismatched the way this is going to, if it works, and if it extends out, it's going to be in the toolkit. It's not going to be first line. You know, do you think of the resources, the training, the cost, etc.? I don't think so. Maybe beyond my lifetime, but if it's a tool in the chest and we can make it available, that's fantastic. Because this, you know, and I think probably if I'm to read the tea leaves, maybe the more someone has emotional dysregulation, the more, in addiction, the more they have self-attacking negative thoughts that maintain their alcohol cycle, maybe the more these compounds are suitable for them. Because they leverage change in emotions and then identity. The less that's the case, maybe people might be exposed and then be a bit like, you know, the biggest fear I've got is that we're going to trial with our patients, and they look at us askance and say, I don't know what that was. That's the fear. So we want it to work. We just shouldn't be we shouldn't over-egg.
Over-egg. I'm interested, Andrea, you were saying that, you know, they need to be in the hand of suitably trained psychotherapists, but we said that last time too. The LSD that was marketed had on the bottle for use by a physician only or for use by a psychotherapist only. So how are we going to prevent the same mistakes from happening?
You're talking now about the 60s and 70s? Or,
Yeah.
Okay.
So last time around when...
Last time around.
was
I
equally
wasn't around
overhyped.
back then, so I wouldn't know. Well, basically, we have methods of preventing that. The first is to have REMS criteria, which is the application criteria for a medication being actually set in the process of turning things into prescription medication. You already see that, for example, for esketamine, Spravato, has to be provided within a medical facility under supervision of a physician, and the patient has to stay for an hour. And you could set as a baseline the same kind of REMS criteria for the other substances has to be applied within a clinical setting after this and that preparation under the supervision of a physician, and integration has to be provided. And this is where it would start. The problem is that, again, the people or the firms trying to promote these substances commercially lose money in the moment, or see they don't earn anything with the psychotherapy around it. They earn per unit of medication sold, and they see the rest as something interfering with their profit, because the treatment gets more expensive the more therapy is needed. And if they want to sell it to health systems, the treatment would have to be as cheap as possible, and as much as possible has to be their profit. So this is a difficult thing to balance, and I think raising awareness and also countering this immense hype. I mean, if you look at the impact, for example, that this Netflix series, How to Change Your Mind, had, it's crazy, to be honest. And this goes far beyond anything reasonable. And let's see if we can take the turn again and move this towards something that can be taken seriously again, because we're getting to a point where it's difficult to find good arguments for our own work.
I would like to say something against John. Okay, so you say that psychedelics or ketamine should be used as third line. I'm not convinced. My dream will be to have a personalized medicine in addiction, to know in advance the phenotype of the genotype of the person that will respond to psychedelics. This will be, I think, the best scenario, not to take as a third line, but to recognize these young people that could respond to psychedelics early age.
Very unfortunately, that's exactly what I was arguing. So we have to agree. No, that would be. If we could have personalized medicine for psychedelic-assisted treatment, that would be absolutely awesome. I mean, and there's some amazing basic science being done. Yeah. You guys are at the forefront of it in particular. Yeah. So yeah, but I think already we can harness individually. You know, so I go back to what I was saying, if I may. We carefully screen, we give someone the time to think it through, to talk to other people that may be baffled about why we're suggesting this or making this available. They have their experience. We then formulate that with them. You know, what did they notice? How do they feel? How can we use it in psychotherapy? And it seems to me it's a decision tree. We're all over it. It's fundamental. It might be a bit ineffable, but they're still making sense of it. But they want to be outside.
Maybe,
for example, then we jump on that. If they say, I don't know, really, it was a bit strange. What do you think? What do you think? I don't know. Then we've got our CBT still in play.
But for example, do we know the people that respond well to AA or therapeutic community? Yeah, do we know the phenotype, or still?
I suppose only that the more severe someone is, the more you're really thinking of abstinence-oriented. But no, we don't. I mean, I suppose that's the point. We desperately need better and, you know, more effective treatments than we have. We don't know much about. We don't have a personalized medicine. There's a tiny bit of pharmacogenetics for alcohol and nicotine, maybe, but not for opioids and cocaine.
But we do know that some of the talking therapies actually work if people have access to high quality talking therapy and they're willing to talk. So how do we?
But that's the thing. You know, we're desperately wanting our patients to do their homework, you know, and then we try to kind of roll with the fact that they lost the behavioral experiment sheet, or the dog ate it or something, and okay, let's get back on it again. The reason why we're so excited about this really is that it could be easy. You know, if we could get that amount of quantum change with that, you know, a single exposure, so that we really are then working to prevent relapse, that's amazing. But it's game on to find out.
Exactly, because there's no evidence actually that there is durable change, even the older evidence.
And the thing about, I always say this, the thing about addiction is that it's like a wily adversary. It's got moves. It's been set up through exposure for months and months and months. It's like a playground bully. It's not going without a fight. It wants more and more of you. It likes it, the fact that you're hurting. And so it challenges us completely to think, can we nudge someone into a different path by that profound experience? It does seem unlikely because the world is saturated with triggers, and they will come back to haunt. And maybe, I mean, people have said this, haven't they, with depression, that phenotypically there may be some patients who will need a second exposure. And I think that may be a fruitful avenue, you know, and maybe with the one we're trialing, it may be that some patients might say, or participants might say, I wouldn't mind trying it again so I'd be more prepared, you know, so I could expect more and get more out of it, or maybe ask questions of it. And so I think it's that the way in which we use it is to be discovered, I think, best. But I think as long as we keep a very, you know, as I keep saying, forgive me, safety and patient-centered approach, that so we're mutually, you know, just empathic and we're open to the experience of it, we shouldn't go far wrong.
But Gabriella, in your work, is there a suggestion that this is some remarkable cure that will make lasting, lifelong change? Is that reasonable what John's saying? Is that one dose, maybe 2 doses, and you're fixed?
So you mean...
With the psychedelic psychotherapy for depression, for example, or for anxiety, is it being held up as a magic cure that you 1 dose, 2 doses, and you're cured?
I don't have a direct experience with patients. We are now running a clinical study, not yet started. But however, I see and I read a lot of writing of people that have used psychedelics to treat depression and PTSD. And what you see from these patients is this magic experience and recovery. It's very interesting because some patients say, I have still symptom of depression. I feel tired, sometimes I'm pessimistic, but how depression affects my life, how now I see depression is far. So this is the spiritual transformation that psychedelics can give. And these people feel relieved from depression. Depression is far. Or people with the PTSD trial, they report my trauma is still there, of course. I can't cancel my trauma. But how I see my trauma, the meaning I can give to my trauma now is different. And this is the transformation of psychedelics with the psychotherapy, with the integration, with the mindfulness, meditation about the suffering. Yeah.
Do you agree it's a lifelong change, magic cure?
The scientific answer is we don't know.
Yeah.
Because basically what we have now in most of the trials is an overview over at the most half year to a year after the application. And we also should accept that limitation. We will need long-term studies looking at people, and I don't think it's a magic bullet cure. And for example, what we see now with ketamine, where we are freer in treating patients. What we, for example, do in our clinic, we treat people with 6 to 7 at the most ketamine. We call them augmented psychotherapy sessions over a period of 3 months, and people usually leave clinically much better. And some of them, after 3 to 6 months, call us and say, could I come back for one more therapy-assisted session, just the one to refresh, because something happened in my life, I'm feeling I'm sliding into depression again, for example, and then we do that. So ideally, also looking at personalized psychedelic therapies, there will be an option for people to come back after half a year or a year for another try. And I think we should not be reluctant to do that, because if what we're doing now at the moment, for example, in the trials, is we have people who do get better, and we have to tell them, congratulations, you got better, let's hope you're not getting worse again, because we have no chance to repeat this. Which is also a difficult situation, because you know then this is working for them, but you can't offer it again. So in the future, there should be, hopefully, also phase 3 trials that don't look into the simple model of one hit of psilocybin, off you go, but look at how often does this need to be repeated, especially for people with more comorbidities, with more difficult situations. And what we also have to see is what we're trying to do in all those clinical studies at the moment, treat pure pedigree problems, like people who just have depression or just suffer from trauma or just suffer from addictions. This is not how people present. They present with a whole bunch of problems, difficulties, and things that need to be addressed. And this needs time, effort, and space.
So, I mean, everyone here is pretty hopeful of the promise, but have we missed the moment? I mean, in some states in the US, I think Oregon is about to legalize or has legalized psychedelics. Have we missed the moment to, and plenty of my clients say, I've had magic mushrooms, I've had acid, and I'm still here. So how do we actually create the space for the evidence to catch up with the hype and the commercial interest? Have you got ideas,
Well,
John?
capitalism won't let us. So is it Colorado that's legalized mushrooms now? I think so. So we won't be able to get a march on that process. And it's a risk, isn't it? Yeah, I think, you know, we run the risk of community harm outstripping medical benefit in the way we're talking about. But I don't think we have firepower to, apart
What are
from
the harms to the community from?
Well,
legal?
I think a prevalence of exposure among people who are vulnerable, who were unprepared. I think hazardous use. I think in a way the same vector of concern about cannabis.
Yeah.
I don't see that there's much difference, except this is a stronger ride with mushrooms. So I think that I've said for ages that we've now got some of the time series. These are just big natural experiments. If that's what society wants to do, then we will as public health professionals we will be part of the evaluation of it. I personally don't think it's a wise move, but that's my own view.
Now, what you say about Colorado is very important. 2 weeks ago, Colorado has legalized psilocybin only for psychiatrists. Only for psychiatrists in a context of psychotherapy-assisted.
You guys need it, don't you?
Yeah. So I think for now is...
It's supposed to be a debate. Sorry.
The psychiatrists or the...
Thank you.
Did you have another comment to make?
No. I took a few seconds to understand that it's a British humor.
Yeah.
We have a few minutes, and I'm really keen to take a couple of questions from the audience for our fabulous panel here. I think there's a microphone around. Would anyone like to ask a question of our panelists? And can you announce who you are first, and then, yeah.
I'm Kelly, I'm from Oregon. And I don't know that I have a question yet. It'll probably come later by myself. But I've really appreciated the counterpoint between everybody because, yeah, we are having some legislative changes happening around the use of psychedelics in therapy, and I'm a licensed professional counselor in mental health and also drug and alcohol certification, so a dual diagnosis. And I feel like I shouldn't I shouldn't be able to prescribe or use a substance, a psychedelic substance, in my therapy at this point in my training, because I can't prescribe other things either. So I'm in favor of things moving a bit slowly and balancing that optimism, because the optimism is real strong in Oregon, in the Portland area where I am. But yeah, I think that could be at the expense of thinking about harm that it could cause. So yeah, I was just very appreciative.
Thank you. Thank you. Does anyone want to respond to that?
I'd like to
Yes,
actually-
thank you, Andrea.
Well, I think having our foot on the brake is the job of the people who have been like doing the science for a while. And it's not that we want to spoil the fun for everybody, but we have to, if we want to do this safely, we have to take down the speed. And the other point is, I don't think that we should even try to match the speed of this development. There's nothing to be won by doing that. And I think what we will see is a separation between the legalized self-experience market and psychedelic therapies, and we should not mix this up. Going for a weekend retreat is not doing therapy with a psychedelic substance. It's a totally different cup of tea. And I think that there's a lot of the vocabulary has to be sharpened on both sides, and I think it's very important also that providers of retreats have the ability to accept their limitations the same way, on the other side, the clinical professionals have to accept the limitations. And then we could perhaps come to a cooperative setting where we don't feel like the other person is stealing our patient or client, but where we see, okay, who can work with this person for their needs best and make sure that these people meet the ideal provider. So,
Please, go ahead.
Thank you. Yeah, hi, my name is David Rizzo. I work at Imperial College, where we also run a range of trials. So I'm one of the ones with a foot on the speeder, but I do agree with also having a foot on the brake sometimes. And in this phase, I very much agree with that aspect. Thanks for a great panel. I have one quick comment, and that's just because there was early on a question on how is it possible to approve these when you have psychotherapy combined with drugs and you can't placebo control them? I think for maybe people, I don't think that was very necessarily very clear. That I think it's important to mention that the regulatory bodies such as the FDA, they have obviously been involved quite early on with some of the companies doing the large-scale trials. So they have been involved and approved the process early on. So they acknowledge that it's close to impossible to blind them. So they have approved the designs in these trials. So they will move towards license despite that issue. They have acknowledged that. I think that's important to mention. Then a quick question, and that's something we sit with at the moment that I feel personally is one of a bit Achilles heel, potentially the most tricky aspect I see. And that's very, very early trauma experience during the psychedelic experience in the therapy session, hidden false memory conundrum, and the responsibility sitting with the therapist. Do you have any thoughts or comments on that issue?
Gabriella, do you want to take that?
So you mean that the flashback, negative flashback?
Yeah, whether it's a flashback that already puts you in the direction that is a hidden memory, that is a real phenomenon. I would personally question that. Is it more dreamlike representation, symbolic representation of something? What is it? It's very difficult to find out, and a massive responsibility sits with the integration therapist, and I feel that's one of the most tricky aspects of psychedelics.
Yes, absolutely. I'm reading now a book on psychotherapy with psychedelics, where one author of the book brings this, and she said that a skilled psychotherapist should be able also to work on negative flashback. So what is thought in psychotherapy. However, the problem of negative flashback and trauma is big issues, in particular with the patients that have also personality disorder, because they tend always to to bring new trauma, to recall a new trauma. It so could be a harmful aspect of psychedelics, it's true. But I don't have an answer how to answer this, how to deal with this. Yeah.
It's a serious risk, isn't it? I mean, it's a safety issue, isn't it? John, did you want to add to that?
Yeah, I really appreciate your remarks and comments and questions. And just on that on the manualized therapy side, I think there needs to be sufficient wireframe of what people could expect to receive that reflects standard care, ideally, within the personalized offer. If that doesn't sound too jargony. We will find out. We're behind you, trying to catch up, if you like. The only thing I would say, I hope it doesn't sound facetious, I don't mean it to. Every time in addiction there's successful treatment, where there's a chronic festering problem, there's surfaced emotion. Always, seems to me. And managing that, recognizing it, interpreting it, sometimes reliving it if we're doing trauma-specific work is part of an addiction recovery story, it seems to me. So just sounds like this is a very, very high-octane vehicle, but perhaps a trans-diagnostic process, something like that. I haven't thought about it much, but it seems to me something like that.
Andrea, I'm going to give you the last word.
This topic of possible false memories coming up in those sessions, I think it's, again, a point where we have to work with expectation management. If people go into those sessions expecting to see the truth about themselves and their lives, this is treacherous. Those aren't truth serums. Those are substances that work metaphorically with associations. They give you perhaps the inner picture of a relative being in an inappropriate sexual contact with you is not about sexuality, but about them crossing your boundaries in other senses. And I think picking up people where they are and working with that, so that after a difficult session somebody doesn't cut ties with their families because they take for face value what they saw, is a huge responsibility. And there will be cases where we will be unable to handle this safely. And I think we have to acknowledge that.
I agree very much. Thanks.
Thank you. Please join me in thanking our panelists today. And thank you all for staying so late. There are canapes and drinks awaiting you. Thank you.